Good morning. I'm Aaron Baker, Shield Healthcare Spinal Cord Injury Lifestyle Specialist, and I'd like to welcome you and thank you for joining us for today's special webinar, Troubleshooting Urinary Catheter Complications with Kelly Sparks. Just a few housekeeping items before we get started. This webinar will be in listen-only mode. If you have a question, please type it into the question box in the control panel on your screen, and there will be a question and answer session after the presentation. If you're interested in receiving CE credits, you can expect to receive your certification via email in 5 to 7 business days. Let's get started. Well, actually, before we get started, I'd like to just introduce Kelly. Kelly has earned her BSN from California State Dominguez Hills and is a graduate of MD Anderson ET program. She is currently employed at Mercy Folsom and provides wound, ostomy, and continence care for inpatients. Kelly has also served as membership coordinator of the Pacific Coast region of WOCN Nursing Society and working member of the Foot Certification Study Project of the WOCN Certification Board. Kelly also has extensive experience in urology. So without further ado, I'd love to introduce Kelly Sparks.
Thank you so much, Aaron, and good morning, everybody. Today we're going to be talking about troubleshooting urinary catheter complications. And we'll start with the objectives. First of all, we always have to have objectives to our presentation. So we're going to identify different types of urinary catheters and review the choice of and the use of the catheters and identify complications that are related to these catheters, discussing preventative methods as well. So as an overview, I just want to go through a little bit of the fact that there are many patients that do have compromised bladder function, and they do come with many challenges and risks. So any type of device that's used, each has its own problems and benefits. So it's important to learn how to care for these patients and to minimize the risks that they have. So we're going to cover how to identify and solve some of these problems and to improve the outcomes for these patients. Types of urinary catheters, well, there's basically 3 types: the indwelling, intermittent, and external. The Foley catheter everybody has heard of, and there's also the suprapubic catheter. Both are indwelling. Men's and women's intermittent catheters are available, as well as in men's and women's external catheters are available. Indwelling urethral catheterization. It is a catheter that's inserted into the urethra and advanced on into the bladder. This does allow for continuous passive drainage of urine from the bladder. Some are short-term, which would be 1 to 14 days of use, anything really less than 30 days. And then, of course, there's the 30 days or more, which is long-term catheterization. That's used to manage urinary retention and incontinence and when other methods are not effective. So what are the indications for IUC? If somebody has severe urinary retention and obstruction of the urine outflow, such as with a prostate enlargement or something, you want to make sure that you're taking care of that so that they don't end up with other problems. Comfort measures for patients who are terminally ill, that's very important to keep them as dry as possible to prevent those pressure injuries that happen. Non-healing sacral, buttocks, or perineal pressure injuries, like I said, stage 3s and 4s, we typically will put in an indwelling catheter so that we can make sure that we can take care of that appropriately. Perioperative use, prolonged surgery, they may leave them in a little bit longer, and surgeries on the organs of the genitourinary tract. They usually will have a catheter in for that as well. There's also operative patients with urinary incontinence that they want to keep that urine from getting all over everything that they're working on. Hemodynamic monitoring during surgery, that's important, and continuous bladder irrigation after any type of genitourinary surgery that you may have blood clots. So they'll usually use that catheter for irrigation to maintain the patency. And also with critically ill patients, they need to have a measurement of the urinary output. That's very important as well. And then with urodynamic testing, we're going to be putting a catheter in every time. Imaging studying of the lower urinary tract, it's important sometimes to have that catheter in place for that as well. So indwelling catheters, you can see some pictures here. There's 100% silicone Foley catheter, as you see, and a two-way catheter that's it's silicone also with an elastomer. So they're coated, and these latex Foley catheters are made from hydrophobic materials that rejects moisture. So it also protects against urethral irritation, and you can see two pictures of those here. Note the balloons on there because that's major importance with maintaining. Indwelling catheters, there's the barred. As you see on the top, it's all silicone. It's good for latex sensitive people. A lot of people cannot use anything with latex, so it's a good thing we have that. And then the Coude tip on the bottom that you see, that has a single eye, and it's a lubricath. It has smoother insertion, and that little tip is used to go around the base right at the curve before you come up, and it goes around the prostate area much easier. It is also hydrogel coated. There is another Coude at the top that is hydrogel coated. It has a raised indicator. You can see on the catheter that little bump. That tells you which way that curve is going. And it's very important to have that curve be pointing upward so that you can go, again, down and around the curvature to get into the bladder. There's also the lubricath Foley catheter two-way specialty that has hydrogel coating, and that does do the hydrophilic cushion between the catheter surface and the urethra, so that helps to be more comfortable as well. There's antibiotic-coated catheters, Foley catheter, two-way silicone 100%, antibacterial-coated catheters. There are many, many more, and I didn't put every one of them in here because that would make this way longer than it should be. So you can certainly look into those. But yes, the antibiotic-coated one is very, very nice, antibacterial-coated as well. So management, insertion, it's important not to inflate that balloon to test for inflation. The balloon inflation should be inflated using sterile water according to the manufacturer's guidelines. If you use saline or other electrolyte solutions, that can cause the crystallization in the balloon's port, which makes it very difficult for removal. So it's important, yes, to read the manufacturer's guidelines, but also to remember that sterile water is usually what is used, and it comes in the kits if they come in a kit. Securement, very important. There can be irritation, trauma to the urethra, urethritis, you can have necrosis, erosion, strictures. Also, the trigone muscle, if the balloon is not secure, I mean, if the Foley catheter is not secured well, it can actually pull down and have pain and spasm from the trigone muscle, just bumping into it all the time. So securement is needed to prevent inadvertent dislodgement as well, but it's really important for comfort. That irritation is horrible when you see somebody with a Foley catheter in that, and the catheter is just swinging in the wind, and they get up, they move and everything. It can really irritate the meatus. So it's important to have the securement devices in place. There are several different kinds. Here you see the more typically the older kind that goes on the leg, and that's best for a female. For the male, it's important that the penis be upright. So whatever securement device you use, you want to make sure that that is actually helping with that. There's the StatLock, which we use a lot of. There's several different companies that make this type of securement device. And then, of course, we used to use just plain old tape. There is some tape here that's better for the skin as well. So securement is very important. Most patients will tell you they have pain if it's not secured. So it's pretty important to do that. So the use and choice of indwelling catheters. If you look at the suprapubic catheter here, you can see that, and I'm going to use my little arrow here, you can see that this catheter goes through the skin here and goes right down into the bladder. And then again, on the female, it's going to come right up and right into the bladder. There's a lot of benefits to this. We'll go over some of that, but it's very, very simple to put in. They use an anesthetic to manage the pain. They cut a small hole in the abdomen, and the suprapubic catheter is placed directly into the bladder. So the balloon is used to keep it in, and then it's attached to gravity drainage bag or leg bag. Again, it's important to have the right amount of fluid in that. You don't want to have too much or too little. It can fall out, and also it can cause irritation to the bladder as well. So why would we use suprapubic? If the urethra is damaged or injured, or if, sometimes the pelvic floor muscles are so weak that they can't even hold in a balloon, regardless. So they would just fall out. So sometimes they have to do it for that reason. After surgeries involving the bladder, the uterus, the prostate, or any nearby organs, they're going to want to put in a suprapubic for that as well. And sexual activity, but they need a catheter for a longer period of time. They can put in a suprapubic and they can still have sexual activity. Long-term use, it's much more comfortable and easier to change than a regular urethral catheter. So a lot of times families, the patient themselves can change this catheter. And it's a little bit easier to do. Actually, it's a lot easier to do. As opposed to the urethral indwelling catheter. So the urethral catheter, of course, goes up through the urethra into the bladder. And you can see on the female here, it's a pretty short amount of distance there. Now on this gentleman, you can see it's a little longer. This is where the Cuday catheter comes in handy, is when you have to make this turn. If you use the Cuday, it is already pointing upward, and it helps to get around that curve and through the prostate. So that's one of the benefits of the Cuday catheter. So the insertion, it's a sterile technique through the urethra into the bladder. The balloon expands to hold it in place. And then again, it's attached to gravity drainage. I wanted to just share with you something that my dad told me that's really interesting. When he was like 5 years old, he used to see his great uncle go out behind the barn. And he always thought that he was just going back there to urinate, But this one time he went back there to see what he was doing. And he actually saw him pull out what he described as a guitar string out of his penis. And he saw urine coming out of the end of this guitar string looking piece of equipment. And then his great uncle just pulled it right out of his penis, rolled it up over his fingers, and stuffed it back in his back pocket. So years ago, that was many years ago, my father's 87 and he was 5 years old then, they did use different, more archaic, probably unavailable to buy now, equipment. And it's a wonder he didn't have UTIs all the time. Dad said he was never sick. So pretty interesting. So the considerations when using a catheter, of course, thorough hand washing before and after touching the catheter is vital. And I'm sure my great uncle didn't do that. The length of time between changes will vary based on a person's medical condition and how long they need the catheter in. And then the user may benefit from drinking extra water. That can help to keep the kidneys flushed out and lower the risk of the urinary tract infection. So even though he was using an intermittent catheterization technique, he still, definitely should have been washing his hands and doing it correctly, but he lived through it. Guess he built his immune system pretty good. Indwelling catheter care complications. There's a lot of discomfort that you hear, catheter-related bladder discomfort, or CRBD. It's the symptoms that they get can include sensations of suprapubic, urethral, and bladder burning and pain, and then also that strong urge to void, and then the bladder spasms. So what causes these? There's several things. There's an intraurethral pressure from the catheter. that can cause pain, the catheter material or the size of the catheter, and then whether or not that balloon is partially filled or filled too much. And then manipulation and traction of the catheter. Again, they need to be secured. The technique and the procedure for the catheter change can cause discomfort. Concentrated urine, blood in the urine as well, local bladder irritation, bladder stones, and especially the constipation and fecal impaction that can happen with these patients that have long-term catheterization. So prevention and treatment, you want to use the smallest size catheter that you can get away with, and that would be a 16 or 12 French. And you want to use the catheter with different types of material based on what the patient's needs are. So securing the catheter and again, the tubing to prevent traction is another way to decrease that pain. So filling the balloon, it's real interesting. I've seen a lot of people say, well, that keeps coming out or that keeps leaking. Well, leaking with the balloon may be filled too full or too little. Most of the time it's filled too full. So you need to fill the balloon according to the manufacturer's instructions, and we'll go over that too. Establishing a bowel care program to prevent constipation when there is an indwelling catheter is extremely important. And then, of course, maintaining the adequate liquid or fluid to get the dilution that you need of the urine. And consider medications to prevent or reduce the spasms. That's another thing that can help. Leakage around the catheter, unstable bladder. Those contractions can just push it, force it right out around the catheter, causing the leakage. So, and detrusor instability. They may need to be medicated for that if they have a catheter in and they keep getting the leakage. But there's other things about the leakage. One, again, that balloon irritation, and we'll talk a little bit more about that. And then the improper catheter size, bacteriuria, impaction and constipation, blockage of the catheter, and inappropriate catheter composition. All of those things contribute to leaking around the catheter. So the balloon irritation, bigger is not better. It's not going to help. If it's labeled 5 ml or 10 ml, both are still can be instilled with 10 ml of sterile water for inflation, but look at the manufacturer's instructions. That's important. Overfilling or underfilling, like I said, that can interfere with the correct positioning of the catheter tip, and that leads to the irritation. So underfilled, that allows the tip of the catheter to tilt down and touch the bladder wall, again, causing that irritation. And overfilling doesn't allow the bladder to empty all the way because then the tip is in a different position where it's not down where the urine is. So overfilling just makes that tip higher up. 30 ml balloons are primarily used to stop bleeding after surgery, so we don't typically put those in patients that need an indwelling catheter unless they're bleeding. Then we look at the catheter size. So again, you want to use the smallest catheter size that allows for adequate drainage, which would be your 14 to 16 French. The size is the outer circumference, and it's according to metric scale known as French gauge, which 1 French unit is 0.33 millimeters in diameter. So that's how they measure that. Okay, let's talk about bacteria. UTIs may contribute to leaking catheters. And again, because of the irritation, we need to get a culture, and it's impossible to prevent bacteriuria in patients catheterized for longer than 14 days. And not all patients have any complications with bacteriuria. Short-term catheterization, they may benefit from PO antibiotics, but long-term, no. That just builds up a resistance to the organisms. So ultimately, the only effective treatment for bacteriuria is to remove that catheter. So it's important if they keep getting it to figure out why, what is actually causing that. Speaking of bacteria and the signs and symptoms of UTI, in nursing home residents, CMS came up with the following rules. And they are, with the catheter, they have to have at least 2 or more of the following symptoms. And you can see them here: fever, new flank pain, or suprapubic pain or tenderness. They have to have a change in character of the urine, either bloody or foul smelling, any new pyuria or microscopic hematuria, worsening or mental function or status, which a lot of times elderly patients with UTIs, that's the only way you know, is because they become terribly confused. Leakage or local findings of obstruction or leakage, mucosal trauma, or hematuria. So fever is the most frequent clinical presentation of UTI in the chronically catheterized patient. Catheter obstruction is often a precipitating event for the fever or systemic infections. So when they get obstructed, of course, that urine sits there, and then they end up with an infection resulting in a fever. So fever with hematuria or catheter obstruction has a really high probability of being from a urinary source. So CMS has those guidelines in place. You can't say that a patient has a UTI without having 2 or more of those symptoms. So how do you prevent bacteria? That's the antibiotic-coated catheters can help. They will definitely delay that bacteria in short-term catheterization. The silver alloy coated catheters are less inflammatory to the system, and they're bacteriostatic. They reduce the microbacterial adherence to the catheters that can migrate up to the bladder. Proteus and Morganella species, they can colonize and produce excessive urease. Urease causes the mucus and the incrustations that can block the catheter, forms the crystals around the catheter and in the bladder. So sometimes irrigation can help with that, but it's better to just change that catheter because it's gone. So fluid intake of 2,500 cc's or more in 24 hours is best for these patients, and regular soft bowel movements are less likely to have the crystallization. Again, that lack of constipation is very, very important for indwelling. Impacted rectum, that pushes on the bladder. That can cause the spasms and the pressure. The pressure causes the spasms, but prolonged constipation can definitely contribute to bacteriuria, in which in turn it causes the spasms and the leakage. So you've got the leakage from the bladder spasms, and all of that can be due to just simple constipation that hasn't been resolved. There are inexpensive coated catheters. They are available. They should be restricted to short-term use. The silicone or bonded ones should be the 2 weeks or longer. They are preferred for 2 weeks or longer because they are so helpful. The positioning, again, avoid tension on that bladder neck. The penis should be supported against the body to prevent tension on the penile scrotal angle. And it used to be, in the olden days, the catheter securement devices for men went around their waist, and it held the penis in an upright position, which is the correct position. Nowadays, we use the stat locks all the time, and the penises are down in an unnatural position. And I really hate to see that, but that's what has come as of late. Secure to avoid tension and keep the catheter positioned below the bladder. That's important as well, so that it can drain correctly. Urethral damage, urethritis and inflammation of the urethral meatus, That can be due to frequent insertion of catheters, if they have to be changed all the time, or they are using intermittent catheterization. Erosion of the urethra, and I've seen that, oh, I'm sure a lot of you have, where it's eroded all the way down. I've seen a penis that looked like it was completely sliced and opened up, and that is just from the erosion. There's false passages. I've seen that as well in men and women, mostly in the males, but I've seen it in females too. Men with enlargement of the prostate gland are most at risk for that. As they're trying to catheterize, they create a whole new area to put that catheter through. Fistulas in females, and I've seen this too, where they get a fistula that's between the bladder and the anterior wall of the vagina. So they present with complaints of leakage and drainage from the vagina. Well, they have urine coming out the vagina. It's pretty disheartening for them. It occurs in men between the prostate and the urethra. Epididymitis, that can be because the urethral and bladder inflammation and a scrotal abscess can form. So we need to watch for these different complications. Bladder stones, at least 8% of patients with indwelling catheters will get bladder stones. And bladder cancer, long-term catheter use, that's a constant irritation, and they are most at risk for developing squamous cell carcinoma. Hematuria can happen with patients with long-term catheter use, and it can also be a sign of a CAUTI, and or bladder cancer or stones. So any hematuria needs to be reported, looked at, and figure out what is the cause of that. Okay, prevention and maintenance. Preventing problems with indwelling catheters, again, choosing a small catheter and a small balloon, or filling it to the correct amount, maintaining good hydration, preventing constipation, routine cleaning with mild soap and water, and sterile technique when inserting the catheter. These are the prevention, to prevent any problems. Those are the things that we need to do. We also need to keep a drainage system closed as much as possible. And, you know, copious lubrication of the catheter using if you're going to reduce the irritation, you want to use a lot of lubrication when you're putting the indwelling catheter in. Secure it, again, to avoid that traction. Cleanse with antiseptic solution whenever the tubing and the catheter are disconnected. That's important, and I think people forget to do that. And then routine cleansing of the drainage bags also helps to prevent with long-term catheterization. So in maintaining long-term catheterization, yes, soap and water, 1 time a day at least, to clean the meatus and the urethral area. And then clean after every bowel movement. You want to prevent any bacteria from getting in there, and avoid pulling on the tubing when you're cleaning, because that can injure the urethra. We don't like to see a bunch of antibiotic ointment or any other antibacterial product applied to the urethra, and actually lubricant, we don't really want to put that on the urethra either. And that's because of the germs that can get up in there. And also, you don't want to apply powder to the genital area or to the tubing when you're using a long-term indwelling catheter. For long-term, cleaning the drainage bag every 3 days is appropriate. You want to have a backup bag or another drainage device ready. And of course, we always have to wash our hands with soap and water. This is this is in the home here. And disconnect the bag from the catheter tubing. Connecting the tubing to the next bag is a good practice to do. And then drain the remaining urine, close the valve. You're going to use some soapy water first, swish it around, make sure it gets in all the corners. Open the drainage valve, drain it out, close the valve, and then fill it with 2 parts of vinegar and 3 parts of water. Shake that around really well, and then leave it in there for about 30 minutes. Then you want to drain the vinegar solution and rinse the bag with cold tap water, hang it up to dry, and you can reuse it. And that, again, is for long-term in the home. Okay, clean intermittent catheterization, which is something my great-great-uncle didn't do. It's safe. It's an effective method to empty the bladder, especially with people who have to do it constantly, who are it's considered as an alternative to a short-term or long-term indwelling catheter. So you have this small flexible, I'll show you some of those, little catheter that's inserted through the urethra into the bladder. Long-term intermittent catheterization is preferable to indwelling urethral or suprapubic in patients with bladder emptying dysfunctions. Intermittent catheterization is associated with an infection risk, but it's 0.5% and 8%. Not that bad. I'd much rather do intermittent. And you know, another small thing that I wanted to tell you about intermittent, I had a nurse friend for many, many years. She was an LVN. She worked in the first hospital I ever worked in. She actually had to catheterize herself every 3 to 4 hours, and she had no problem with it. She carried him around in her pocket, and she would go in, and she just had no other way of avoiding, so she had no problem with it. I'm sure she still does it to this day. Urinary incontinence, these indications for IC. You know, again, it's an alternative to short-term or long-term. Acute urinary retention without bladder outlet obstruction, and then chronic urinary retention as an alternative to the indwelling catheter. It's also used to install medications into the bladder and collection of random urine samples. So there's a lot of reasons why people do IC. Here's a picture of some of the more common kind. There's one that is in a package that just looks like a curved little catheter in that package. It's a sterile packaging, and it has straight tip, smooth eyelets for comfort. It has a flexible funnel that's easy to hold on to, and it's latex free. And then below you see the red rubber straight catheter, and that is latex, and it has a straight tip. Those are just two of the many. There's many, many brands out there, many types. Bard has a clean intermittent catheter. You see at the top. My favorite is the middle one, which is the closed system. The closed system that has an introducer tip, and it's so easy for people, and it's so much more clean, sterile. You get your urine right in the bag, and then you can go empty it or throw it away. Very simple for people who need to do this every few hours. And then, of course, there's the red rubber that is coated with a very slippery hydrogel for ease of insertion. I remember when they first came out with that, with the introducer tip intermittent closed, and that was a huge thing for a lot of paraplegics that have to catheterize all the time. It's a wonderful system. So with clean intermittent catheterization, there are many reasons, especially chronic urinary retention. People with neurologic conditions, there are complications with this, and they are UTIs. You can see them listed here. Stenosis, prostatitis, epididymitis, urinary lithiasis, and urosepsis. Those are just some of the complications. There's a pilot study. This was done by Rosemary Bollinger and Sandra Ingberg. This was put in the Journal of Wound Ostomy Continence Nursing in 2013. What they did was a cross-sectional survey design of 44 community dwelling men and women. And these people used CIC for 2 or more months. I found this very interesting. the diagnoses that they used in their study, the majority of the patients were of multiple sclerosis. There was 21. 9 of them had neurogenic bladders, as you can see, and then urinary tract infection was 2, along with spinal cord injuries was only 2, and then prostate cancer. But mostly the MS patients is the people that they did this study with. They found that the barriers for them to do their intermittent catheterization, the main one was public bathrooms. You know, there's no sinks in the stalls. Unless you get in one of those handicap ones that might have a sink in there, but most of them don't. There's no shelves in most. There's no space, nowhere to set anything. They had trouble with that. And then with females, positioning was a problem. And mostly probably with the obese patients. The inability to sense or feel the catheter being inserted was also a problem, along with the cost of supplies. Visual problems made it difficult to insert catheters as well. So, you know, when I used to teach intermittent catheterization, we taught it all by feel. Every bit of it was by feel. And I had a blind lady one time in the hospital that I had to teach how to do intermittent catheterization. And she was actually, of course, because she was used to feeling things, but she was actually easier to teach than patients who had vision. So I found that very interesting. She did very, very well with hers. And she was thin enough, she was the right everything, and it was all by feel. So that it worked out really well for her. And then there are complications of this study. Urinary tract infections was number 1. And then bleeding, stone formation, and then the other things. So it really is, it was a great study just to show those different things. So the most common barrier, again, was the bathrooms. No sink in the rooms, there's no shelves and inadequate space. And then the other common barrier was muscle spasticity for the MS patients. Urinary tract infection was number 1. But there needs to be more studies. Those of you who are out there doing your PGPs and whatever else, you need to do studies on this, because we need to look at the occurrence of UTIs in people who reuse their catheters multiple times versus the ones who use single catheters. One time, a long time ago, I was helping out with home health, and there was a patient who I think was an MS patient, I can't remember, but they reused their catheters. She used the 6-inch, you know, the shorts, and they would actually put them through the dishwasher. Yeah, and use them. The other patient, another patient that I saw, she would wash them out in the sink, and then she'd put them up stand them up in a cup to dry, and that's how they did it. She had very little UTIs. It was amazing. So there are specific challenges for the patient with IC. Different things like, again, the inadequate or inaccessible bathroom facilities. That's a huge thing. Inconvenience or difficulty with cleaning the catheters. You know, they don't feel like they can carry and reuse their catheters. And then there's the cost. If you use the ones that are indwelling or that are self-contained, they may not be able to afford those. Inability or unwillingness to perform frequent catheterization, so they end up getting all kinds of problems from having too much in their bladder. Anatomical constraints, you know, false passages, bladder neck obstruction, urethral strictures, all of these things can be challenges for them. And then, of course, the physical limitations, difficulty positioning. Females have problems with that. And some men can't even see it. So how are they going to do that? And then upper extremity impairment, that's a little difficult too. Comorbid conditions, the inability to feel the catheter being inserted. And then again, spasticity and obesity, it makes it very difficult. And again, we'll go through the complications here, bacteriuria, 50% often are colonized, rarely leads to UTIs. And again, they have, majority have no symptoms, and therefore they should not be treated with antibiotics. 20% annual incidence, most common cause of sepsis is urinary tract infections. It's more prevalent in patients that have a higher residual urine volume, like over 400 at the time that they catheterize. And chronic pyelonephritis rarely develops in these people. Urethral damage is a problem. Urethritis, the inflammation. Urethral stricture is a result of the inflammatory process there, and increase with the number of years performing CIC. Difficulty with insertion is a sign or the presence of urethral strictures. And that again can cause them to end up with a false opening there. And there again, creation of the false passage that can occur because of those strictures. The passages occur because of trauma to the urethra and the side of the external sphincter. Prostatitis, yeah, especially in aging men, and epididymitis due to, again, that inflammation, and scrotal abscesses are seen in men. Bladder stones can occur in patients who perform CIC long term. And stones have been shown to grow around and introduced pubic hairs. So that's you know, quite a problem for some people. They really should shave as much as they can and prevent getting those hairs inside. So let's talk about male external catheters. There's quite a few. We've all seen these. They decrease COTIs in hospital, decrease COTIs at home, more comfortable than an indwelling on a lot of people. There's many, many different types, and they also have, for the retracted penis, there is a retracted penis pouch. I've used that on people, worked pretty well. And ease of use, anybody can do it. And I have to say, the one time that I was really upset about a male external catheter is there was a paraplegic man who was adamant about putting it on himself, which was great, and I let him do that. At the time I wore contacts, and I was standing next to him, and he went to put it on, and he snapped the catheter somehow and threw a spot of urine in my eye. That was not fun. So of course that was at the beginning of needing to go and you know, rinse out, take the contact lens out. It was horrible. So I really watch that now, and plus I wear glasses. So, but active cath, you can see on the top, the active cath, it's self-adhering. It's a one-piece latex catheter for active men who prefer extended wear. And then the Freedom, the clear long seal external catheter you see on the bottom, that's silicone. It's also self-adhering. And these are pretty easy to put on. They kind of roll down across the shaft of the penis. The top one, the Covine, that one is fairly new. It's new to us in our hospital, and very easy to put on. It's reliable as well. It stays on really well. And then there's the old one-piece latex non-self-adhering catheter that has it has a high supportive cup, and that prevents twisting, which is good. And it has a 1-inch foam strap to hold it on. And there's some issues with that if people put them in or put them on too tight. That can be a real bad thing that they can do and get them injured from that. Hollister has the extended wear male external catheter. That has an inner flap. It's quite nice. It has this inner flap that minimizes the urine flow back, or backflow that goes back over the penis. So that helps with the skin care. And then the Invite Extra Adhesive Male External Catheter. That's made to be comfortable with transparent material and adhesive inside. It's also a nice catheter. So the male external catheter care, changing them 24 to 48 hours will decrease the rate of infection or the chance of infection. And it may need to be changed more often depending on the weather, whether it's hot and humid or not. Also, again, you want to trim the hairs on the shaft and the base of the penis so they don't stick to the adhesive. It's very painful when you try to take those off. And then washing and drying the penile shaft before and after. I mean, before you change it, before you put on a new one, you want to wash and dry very, very well. If they are, you know, if the patient has a risk for possible breakdown, you might want to use some of the barrier film as well. That helps. Avoid the use of betadine. That can irritate the skin. Phimosis is present when the orifice of the foreskin is constricted. So you want to prevent retraction of the foreskin over the glands. This can occur as a result of overconstriction of the penis from a condom catheter. So you want to make sure that you don't set them up for phimosis. Female external catheters, something new on the market, and we love this. This is the PureWick. We've been using this at Mercy. It's wonderful. It's wonderful. It's simple, non-invasive urinary incontinence management for women. It attaches to the hospital wall suction, and it aligns, as you can see there, against the pubic bone. This part over here, it gently wicks away from the patient. This is a soft material here that sits on the patient, and then the end of it tucks snugly between the gluteus muscles. Now I have to say something, not our hospital, but one of the hospitals, one of the, I think it was an aide, went to put this on and thought that this had to be inserted into the vagina. So that was not a good outcome. And the patient's the one that complained about that. So you want to be careful also when you're putting this between the gluteus muscles. You want to be careful that you're not causing undue pressure there as well. But it is soft, it's flexible. You position it between the female labia and the buttocks. You must open the labial area and put it right in between, or it will not work well. And again, to low wall suction. I found one at 80 millimeters mercury, which is not low wall suction. And that lady did complain of pain. It can be used in a reclining position, laying on the side, laying flat, or while seated. It's a very effective method. I am so sorry that I didn't invent this, because this is huge. It's such a wonderful thing that we have. Sage puts one out as well. I have not tried this one. This one, however, has a tape that goes across the lower abdomen that might help hold it in place a little bit better. It again fits between the labia and it pulls the urine out into the canister. The patients have been very supportive with this PureWick. The patients have really liked it. It keeps them much more dry. You do have to put a pad underneath just in case they leak, but it really keeps them much more dry, and they don't have to have Foley catheter in, which of course is going to decrease your hospital-acquired urinary tract infections. So I could sell these things, I tell you. Little bit of pearls having to do with that. It's not appropriate for confused patients. They don't know what's going on and they pull it out. It's not appropriate for patients that move around constantly. They need to be able to know that it's there. And again, low wall is 40, and you want to change it every 8 to 10 hours. We do it every shift, and it's not appropriate with loose stooling, obviously, because it's going to clog it up and you could put them at risk for infection. And at each use, you want to clean the skin. This is sitting on the skin. Again, have a pad under them, and they have to be placed correctly. They do not go inside, and it will decrease the caudis, like I said. There are references that are available for this talk, and thank you very much for listening. I appreciate it, and I'll see you next time. I think, yeah, he's going to come on.
Here we go. Wow, thank you so much, Kelly. That's an incredibly informative presentation. I'd like to just take a quick minute to let everybody know that we have an online support for patients and clinicians at shieldhealthcare.com/community. We also have free educational booklets. Go to the next slide here. And that is for patients and healthcare professionals that we can request guides online. We also have urological supplies available nationwide. We have urological supplies from leading manufacturers. We have resource and educational information, a wealth of resources including urology, caregivers, incontinence, spinal cord injury, and skin preservation. We have a strong presence on social media. That's the way of the world these days: Facebook, YouTube, Instagram, Twitter, and more. You can find me, Aaron Baker, among the social media platforms. And also, your CE Contact Hour is by Capital Nursing Education. The Contact Hour will be issued via email directly from Capital Nursing Education within 5 to 7 business days. So I just wanted to let you all know. Also, the seminar is available online. For more information or ask questions about the presentation, contact Shield Healthcare, the marketing at shieldhealthcare.com. So that concludes the webinar today, but I would like to open it up for question and answers. We have a first question here from Amanda Kelly. Is the intermittent cath a one-time use, or do you use a new one each time?
You know, that depends on the patient and what they're using it for. Sometimes, like I said, patients will, in the home, if they're using intermittent cath often, they will wash them, allow them to air dry, and use them again. But if they're active people and they're out, you know, out and about, then they're going to probably use the closed system, and that's a one-time use.
Very good. Here's a question from Barbara. What causes bleeding with the insertion in prostate patients?
You know, I think irritation of the prosthetic urethra right there it's very sensitive area, and I think that just the angle of the catheter, if they use a Q-day, the chances of irritation and bleeding are less if they have a terrible enlarged prostate. The other thing is, you know, the inner sphincter. I had a urologist tell me this once, and it's a great way to think about it. If you go to put a catheter in and you meet resistance and you push harder, it's going to make that sphincter tighten more. And then you can irritate it and cause bleeding that way. So he told me, when you put a catheter in, you want to do steady, easy pressure, but steady pressure. Instead of knocking on a closed door, you want to just slowly slip that door open. So to prevent that bleeding, etc., it's much better to do it very carefully, slowly, and not cause irritation that can cause bleeding.
Makes perfect sense. Here's a question from Ellen. Are there less infections with the suprapubic catheter?
Definitely. I think so. Because with a suprapubic catheter, they can see it, clean it. It's not down in the vaginal area, or, you know, it's, especially women, it's much easier to see and clean and take care of. So I would imagine yes.
All right, great. Well, this has been an amazing webinar today, very informative. Thank you so much, Kelly. We appreciate this wealth of information, and I hope that it really helps out today. So,
thank you, Aaron. I really appreciate being here to do this. Thank you very much.